Hi, my name is Sofia Cuba. I am a family physician from Peru. I am also faculty in the Cayetano Heredia University, that is a university that is located in Lima. And in the past 15 years, I was involved, and I am still involved with teaching residents and students about family medicine and primary care. We also have a master program of primary care in our university. So I am leading this program. And also recently we started with a Center for Research in Primary Care. And we are starting to do more research related to how to implement a primary care system in our country. That is something that is very many people talk about that in the government, in the directives, in the laws, but it's not implemented in the way people feel a difference. So the reason for this research center is try to make something that could be evidence of how to do it in an environment like Peru.
Okay, so thank you very much, Olga. My name is Dr. Fosuhine Kusi. I'm the Municipal Director of Health for Techiman Municipality, and I also double as a family physician with a couple of years experience. So, but now mostly I do more of administrative work and a bit of clinical work every now and then. So basically that's my background, the health administration and family medicine practitioner.
So thank you, Olga. I'm Dr. R.K. Prasad. I'm a family medicine physician, also trained in public health and infectious diseases. My own background is I was born in India. I grew up in India. I grew up in several different cities of India. And then I finished my medical school in India. Once I finished my medical school in India, my first job actually was as a clinical tutor in pathology and microbiology at St. George's University in the West Indies. This was my first kind of exposure to being a healthcare professional or even being a person out of the country I grew up in. Subsequently, I studied public health, did a master's in public health with a specific focus on infectious diseases and microbiology at the University of Pittsburgh. And after that, I did a short stint as a visiting assistant professor of epidemiology at the same university. And then I did my residency in family medicine, also at the University of Pittsburgh, but this was in a special track, which was called the Global Health Track. After a couple of years as faculty, I actually left the US and came back to India. In India, I have been I've done my own thing. I set up a couple of organizations and have kind of learned several things which would broadly be characterized as entrepreneurship or social entrepreneurship.
For our conversation today, we're going to talk a little bit about colonialism in global health. And I was wondering if you could think of some examples of global health practices or behaviors that you've noticed that are rooted in colonialism.
Yeah, I think these kind of practices are changing now. It's a trend that is going to be different in the next years. But I think in the past decade or maybe before, when I think at the beginning of the century or the last decade of the last century, we have like this tendency to vertical programs, especially for primary care. And most of the research in the vertical programs was led by people in high-income countries, even though they have a lot of experience in public health field, are probably in practice. They probably do not have the experience of living in the country in the conditions of the country. So one practice that I studied and see a little bit in the past is that there were big programs with funds that only were led by people in the high income countries, and usually people in the country that the intervention is going to be done. They work in the program, but they are not leading, and sometimes they are not acknowledged in, for example, in the papers or in the documents that are related to the program. But I think this practice is changing, and there is more awareness that it needs to be equitable, and usually now programs are like having one lead of the country, low middle income country, that probably is the place where the intervention is going to be done, and one lead of the high income country. But it still happens that there are programs that the leading is more focused in the country or in the persons that are in the universities of the high income countries.
Okay, so thank you very much for this question. I think we are all very much aware of the historical perspectives of colonialism in global health. But let me start from medical school, where doctors go through the formative process. I think in medical school, the training is modeled more on the westernized way of training. For example, if you came to Ghana, I could say it's just a replica of the British system. So, I mean, right from medical school, you realize that some of the context are very steeped in British, should I say British thinking, British way of doing things, and then it goes through and through. So I think from the formative and training years, you have colonialism in a way influencing attitudes and the way doctors might practice in future. So it's something that has been recognized in Ghana. Some of the much more recent medical schools are adapting to programs that suits the local context. If by example, the University of Developmental Studies in Tamale, they've taken a more local context approach. And I think it's making their doctors very comfortable to go to rural areas of Ghana to practice than, say, a doctor who trained in Accra or Kumasi, let's say University of Ghana Medical School, which is your typical classical British way of training, would not likely go to an underserved area to work. So I think right from medical school, you have these influences. Other examples which are maybe more cultural. People might not understand the cultural context. Let's say a typical example would be, let's say a woman is say gravid at 6. A Western practitioner, the first thing that will come to the mind would be she needs family planning. But then if you came to the local context, having many children, it's kind of even glorified, and there was a reason for that. Neonatal mortalities were quite high in those days, so the culture was for women to have more children, and then at least some would survive. So let's say if she had 6 or 7, and she even lost 3, at the end of the day, she will still have her 4 children. So in addressing some of these issues, family planning may not necessarily be the first solution, but to tackle it from a cultural perspective, where you explain to the women that, look, our grandmothers, great-grandmothers had many children because neonatal mortality was high, and now neonatal mortality rates are low. So you can juxtapose it to, so I mean, if you have, say, 3 or 4, quality of healthcare has improved. and then your children are likely to survive. So you don't need all that 6. Instead of people just saying, oh, they need family planning, we should give more money for family planning. Maybe we don't really need money for family planning. I would need money, probably just a little money, to address some of these socio-cultural perspectives. So these are some of the examples I think I can give for now. I think, as we may all be aware, usually in terms of funding, either it's a proposal is written, and then the proposal is accepted through all those funding cycle, or sometimes there could be, say, in the case of COVID, there were WHO came out with tailor-made, some tailor-made solutions, which may not be very applicable or practical in certain countries. And some of these funds came with very strict expenditure rules or usage rules, and sometimes it kind of limits how we are able to do innovations and modifications to these funds. So primarily, it's not really about who controls the funds, but I think before funds are disbursed and those things, we should create room for innovation. We should understand the local context, country-specific context, and then all those nuances surrounding these things.
I guess thinking a little bit about like the specific global health practitioners that you've interacted in different levels, maybe somebody who came and they wanted to help you or your colleagues and they were in Peru. Can you think of some examples of their approaches that were not helpful or maybe even harmful?
Mm-hmm. Yeah, I think the approach where people think that or come with a framework that they think this is the solution for a kind of problem, and they do not take in count what happened in the country because of policies, because of corruption, because of many issues, and the reality of, for example, health workers is something that is destined to fail, because sometimes they think because the framework or the thing that they researched before is like the way that you are going to do in every country could be harmful, because no, it's not the same reality, and probably they need to be aware of all these problems we have. The thing is, usually people that behave in that way, they have this, like, I don't know if it's like inconscient way of thinking that they are like, they know more, they are superior in some way of maybe a scholar way, so they have the reason. And I think it's not a thing that only happens from researchers abroad and researchers in the country. Also happens, for example, I work in Lima, that is the capital city, and we have like 1/3 of the population and big universities here in comparison to other universities in other regions in the country. And it happens also with researchers from Lima, with researchers in other regions, bigger universities tend to believe that they are the owner of the truth. And I think it could be a mistake from researchers from abroad, and also researchers in the same country that have a bigger trajectory or are working in a bigger university.
Okay, so that's a very good question. I think the first I'll start with was right after medical school, I had the opportunity to work in the upper west region of Ghana, which back then was a very underserved community. And we had these Cuban doctors who were the Cuban brigade, they come to developing countries to practice. And then there was this particular Cuban doctor who would have, anytime he did a cesarean section, would have issues. So there was a day I engaged him, and then I was like, is he an obstetrician? How many years of training? And apparently, it turns out that he was a plastic surgeon. And for me, it was such a huge shock. It looks like coming from Cuba and then the West, probably somebody felt, hey, these guys would follow all the medical ethics and all those things. So I asked him, so why would you be doing obstetric cases? Like, okay, we had some hands-on training for about 2 weeks when we came, and for me, I felt, oh wow, this is a bit experimental. Aside that, I've had a few cases where, let's say Nalergo, I'm sure we we met briefly in Nalergo. You had American doctors coming in. I think the idea was great. People, and my experience in Nalergo was I found out that some of the measurements and indicators we're using was in American. For example, in Ghana, we use, say, millimole per liter for our sugar readings, glucose readings, and the rest. And it was in milligram per deciliter. And I realized some of our nurses were struggling to do the conversions. So maybe for an American practitioner, that sounds so easy. Oh, milligram per deciliter, but a Ghanaian nurse or doctor is trained in millimole per liter, those little things. And then in one other outreach program, I realized that surgeons had been sent to Ghana, very great surgeons, but these were people who were more a little biased towards doing laparoscopic and endoscopic surgeries than, say, open laparotomies. And here they were in Ghana, and then of course we don't have all these fancy gadgets for laparoscopy and endoscopy. So then some of them had some training in open laparotomies, but then you realize if you had more experience with open laparotomies, you realize there was a bit of a struggle. So these are not ill-intentioned things for me, but I think if, say, people decide to come to Africa to do, say Ghana to do a surgical outreach mission, I think they should stick to what they currently practice. So let's say if you do endoscopic surgery, I was thinking that maybe we try and bring down some endoscopic equipment. You do the endoscopic surgery, do some skills transfer to our local surgeons. But then in a way, sometimes it's like the skills transfer is a reverse. That's not bad. We can also teach some open laparotomies, and then we get our endoscopic trainings. So these are some of the few things I've come across.
About situations where people, some providers from the US and maybe even some, let's say some folks who are maybe even originally from Ghana and they grew up in the US, right? And they want to go back and they want to do something nice and they want to go back to their village. And what I see sometimes is sort of some of them organizing brigades here with their colleagues. Most may not be from Ghana, right? And sort of like these, or maybe somebody who is not at all from Ghana, but has a relationship with a town, a village, an area, and they just go in to help out and start developing projects and work there.
This reminds me of Sampa. So we had such a similar situation where a brigade decided to come into town. I mean, instead of speaking to the medical team, I think they spoke to the politicians, political figures first, and I'm sure what the political figure will feed you with is going to be something that might give them political votes. So the whole team came, and out of the team, we had very few members of the team who were useful. I mean, the rest were very redundant, but if the team had spoken to us, we could have told them what the priorities were, what would work and what would not work. Like you rightly said, I'm sure some even donated certain equipments that could not be used in Sampa. And at the end of the day, we had to send those equipment to Sunyani and Kumasi. So what I would advise is good. It's good to go back to help, but speak to the local people first, the local health authorities first, those who are in practice. Let them prioritize their needs. So for me, I say, you can ask me to give you a list of what my first 4 or 5 priorities would be, and then we can discuss what the team can easily handle or what they can't handle. And then together, because at the end of the day, when the team leaves, I think it's about helping develop health service delivery, helping solve problems. I don't think it's just a medical tourism or a medical vacation. So these are things. So at least the health authorities can give you a plan of what their needs are, and then based on that, we all prioritize together. And then I think it becomes more smooth sailing. Let's say people have brought in dialysis machines to places where we don't even have the medical expertise to man these dialysis. Then the dialysis will become a white elephant sitting in that hospital, probably, who knows, will never be used or would have to be redonated. So these are some of the practical experiences I've had.
The primary question you asked me was, how should these relationships be more equitable? Um, I'm forgetting the exact wordings of your questions, but 2-3 things. One is that there has to be a sense of partnership, co-learning. So just to one of the things is, many times there are lots of partnerships between a developing country institution and a developed country institution, but it doesn't actually result in capacity building locally. It results in a lot of, for example, data, publications, uh, prestige for the investigators involved, and usually um, the uh, the developed country university or institution gets credit for this. It also, there is funding usually comes in, but usually the funding is linked with the foreign university. Many times it doesn't result in local capacity building. Two, 3 things which also happen, which I think have a perverse impact. One is the local uh, uh, faculty champion or whoever. Sometimes, and I've seen this in some countries, where if you get on, for example, the local university or the local institution may be able to pay you a salary of, say, X, which would be kind of maybe perceived as a reasonably decent salary in the local context. The foreign partner, if you are on their payroll, you may get something which is nearly 10 times more, and which may be seen as a reasonable thing by, say, the developed world standard. But this creates a huge kind of a disparity within the local institution. For example, if say I'm the key um, um, faculty collaborator, and say my salary becomes like 10x of what someone with the same rank or a rank below is, who doesn't have the same network as perhaps I possess. So then this can have a lot of perverse kind of implications. The second is, uh, exchange of students and ideas. So obviously the ability to kind of travel and move uh, for students from a privileged country setting is way more than for someone in a developing world country setting, um, both from economic point of view and in terms of just structural restrictions like visas and um, and I think in my interactions with various global health um, uh, groups and universities, one of the things is, one also has to understand that global health is an endeavor which is quite attractive to universities in terms of their competitive edge within their national or regional context, because it attracts bright people, it attracts people. I think these are all things to kind of keep in mind. What I have done in my own, wherever I have in my own zone of influence is, number one, I actually value global health collaborations. I do not look at them as necessarily negative. They are not negative. They can actually have a lot of positive impact. So it's so the whole idea as a whole is not something I shun, or something which I think is necessarily um, negative. It actually can have a lot of positive things. But the structure of relationships have to be designed in equitable ways from the get-go. I will also acknowledge my own positionality here. I am in many ways very privileged because I have trained both, say, in a developing country setting, but also spent many years as in training and also as faculty at a leading university in the US. So, and I have been on the global I've seen this global health experience from multiple different perspectives. Um, um, so the certain things which I may be able to both understand, be sensitive to, and be able to navigate, negotiate, may be different from many other players, partners, individuals. Um, I think learning has to be the key goal. Capacity building has to be the key goal. I'll just take a minute to talk about innovation. So sometimes what happens is what looks like a capacity building or global health partnership kind of objective may not be that way. For example, if I've seen it with certain institutions where, say, they've developed a protocol, laboratory protocol or something like that. It may be so restrictive that actually a developing country partner, it restricts the innovation process. India actually, I think, is relatively better off in that way because it's got a larger pool of professionals. It's got a larger, pool of people who can navigate. But honestly, a lot of solutions can be arrived at and can be scaled at like a fraction of the cost it takes to uh, you know for what it might take at the CDC or someplace else. Mm, I think the recent moon mission from India is an example. So, so one of the things which has been making the rounds is, yeah, the one of the movies that talks about space travel cost $150 million, but the whole program that the ISRO, Indian Space Research Organization, made, which this thing cost $75 million. So there's actually, I've seen this in the laboratory space. I've seen this in primary care protocols. Global health cannot be an enterprise of I know it. It works in my settings. I've got the right ethos, intentions, and I've got the right vocabulary. And here I'm exporting it. You just take it because the context is different. So I think to conclude, the principles of family medicine and primary care hold good and apply in very very useful ways to the enterprise of global health. There has to be, so relationships have to have continuity, there has to be equity, and there has to be co-learning. Learning is something which actually makes people come together, and I think the process of learning brings together certain forms of equity, which I think are really worthwhile. There has to be an openness to understanding that there are a host of innovations that and adaptations that human beings and teams kind of evolve in their local context, and the effort can never be to kind of correct them. They have to be the what perhaps one can benefit a lot more from co-learning and exchange.
And sometimes we found a way of going around a problem that probably you guys will be using all your fancy machines. And I think there is always learning is always a two-way affair. I think when people join, when they come in these collaborations, they go back, they tell you the feedback we get is they've also learned a number of things, and from the feedback we get with them, we realize they really appreciate how we've become very innovative with clinical medicine in the midst of let's say that our technological deficits and the rest. So we found ways of surmounting certain problems, which probably might be unheard of in the West, because probably when you have all your gadgets, all your diagnostics, you wouldn't be looking at other options. We've come up with very simple solutions to some problems that I'm sure a lot of our colleagues marvel at when they come to Ghana, and they are really impressed with. So there is always that room for bi-directional teaching.
When you engage, it's not about getting your work done. It actually is about learning. And for faculty and for leaders, it's about catalyzing that learning, co-learning process, and being very cognizant of the values driving a partnership. One thing that recently I've been thinking quite a bit about, thanks to my good friends and collaborators, is we've listed down 8 values that we feel are values that we will both espouse and kind of adhere to, such as humility, intellectual curiosity. Intellectual curiosity is a huge one. Accountability, but accountability to whom? To communities that you are at least saying you are doing this to serve, right? Any proposal you look at is will not look like an imperialist project. It'll sound like it'll have all the right um, um, and commitment to diversity. Diversity can be of so many different types, right? Like including diversity of thoughts and um, models. So anyway, I think to answer your question in one line, it's about navigation begins with clarifying your values and and truly sticking to those values. Some principles. Number one, if you're, I think it's generally advisable to forge collaborations with people who understand this. Understand this in the sense who can navigate, negotiate the values, ethics, ethos of this. For example, if Olga, you reached out, I myself may reach out to you and say, hey Olga, you're a wonderful person who is like working on migrant health. You're doing your own thing, and I can imagine how rich and how challenging that must be. Then you're one of the family physicians who's faculty but also does obstetrics. You have a lot to kind of share and be a role model, right? So if you came to say our department and spent a few days with us as a visiting faculty member, I think I cannot see anything that negative about that. And as a part of that faculty engagement, if this became, for example, a longitudinal engagement, where you said, I have this site in India, I have these bunch of friends in India, and there is this exchange which goes on. But linked with that, if there's also humility or curiosity, you say, hey, how does it work? How does obstetrics work in the Indian context? I see that there are lots of cesarean sections. Or how does this work? When it's associated with that deep desire to understand context, to improve or innovate within that context, which can result in that cross-sharing. If you also facilitate, for example, some of the residents or young faculty in a department here to have to forge friendships and networks back in your institution, and say there is collaborative research, teaching, faculty development, etc., that emerges from this process over a 5 to 10 year period. there can be a tremendous amount of positive impact. I think that's kind of the way it would be done. But if on the contrary, someone shows up and says, "Look, I know how to do this. I did this," it's not going to work. Second, it's not going to result in a model which is ready for either uptake or non-abandonment or spread or scale or
It's not that you're saying that please don't come to Ghana. We're good. We don't necessarily want you here. You are saying we absolutely would like to partner, but in a way that actually fosters an equitable collaboration that's driven by our priorities and needs and goals and our understanding of the local culture.
I think that's a brilliant summary.
And I think that a lot of times what I hear from some of our providers is that they don't know how to identify the leaders who they should be talking to because they're new and they're relying whatever connections they have, but they, like thinking about our family physicians who might be the primary audience of this presentation. What advice do you have for them in terms of how do they figure out who they should and shouldn't trust, who they should and shouldn't work with to make this a really truly equitable partnership?
Okay, so that's a brilliant one. I think the organogram of the Ghana Health Service or the Ministry of Health, it's easily accessible. So within each district or municipality in the country, there is a municipal director of health within that municipality. So let's say wherever you want to work in, Ghana currently has 16 administrative regions, and within each regions there are districts, and each of these districts has a health director.
I think that the way now I feel they are approaching is trying to find people that are like with some skills like the language and the experience, and it's good because you are going to go faster. But in order to think about equity in the future, I think maybe they need to look for researchers that could have like a barrier of the language, for example, and try to make it different for them, or because they have a lot of things to do, and sometimes language is a big barrier. So I found, for example, in some collaborations I am now that they try, for example, in like little meetings, try to put a translator. That's a good thing because even that the researcher knows how to communicate in English, could be better to express some things in their mother in their own language. So like trying to decrease the barriers like the language or special trainings that could make those people that have a lot of experience fit in the way they are doing the research could be something important. Also, that the collaborations need to be in both ways, because there is always something to learn about what researchers in other countries are doing and the way the health systems are performing. Even something could see as catastrophic. There are some things that a different kind of situations make the system or the people behave in a way that could be an example for other systems that face the same problems. Probably in the future, trying to move the center of the training and knowledge that is more focused in big universities in high income countries to, for example, low middle income countries universities, like trying to make collaborations for example, for scholarships or trainings, like those trainings could be done in their country university at the beginning, maybe with some help with the big universities, but starting to develop capacities in their own country to do it in the future, because 30 years, 40 years, or 50 years of people going to do like a postgraduate training or something in other countries is interesting in some ways, but should not be the norm in order to have a like more experience or more knowledgeable degree. We need to develop more proficiency in our own schools, in our own universities, to make it possible to have excellence, spaces of excellence, academic and research, research spaces of excellence in our own countries.
One, we need to be having open discussions. Personally, I'm very happy we are doing this. I think the more we talk, it gives us the various dimensions. The understanding becomes broader, and together we understand each other, would come up with common goals, and we'll realize that we are partners. We are partners in global health. Apart from that, I think respecting each other's opinions really matters. And whatever way we decide to look at things, each health sector would have its superiority over the other. Personally, with COVID, you realize that I think all the model predictions for Africa failed. So it tells you probably we also have something up our sleeves. So let's get talking more. Let's understand each other more. As family physicians, we already know medicine goes beyond just diagnostics. We look at all the other determinants of health together. And I think by so doing and talking more, probably sharing more presentations, more experiences, working more together, in a way we become more like co-equals, and slowly we'll be able to take off the veil of colonialism in global health.